So we'll stop recording from now. If you don't want to be recorded, obviously, please don't turn your cameras on. Thank you.
Okay. So Macmillan commissioned a report as well that said that, you know, community end-of-life care, and that includes pharmacy care, was one of the few interventions that might be effective in reducing that reliance of people at the end of life on emergency or acute care, and once again showed that, you know, community care as opposed to emergency and hospital care can save a lot of money. So they were just looking at cancer patients. So they was talking about figures of £104 million a year. So, you know, we know that that in reality could be a much bigger sum if you look across the whole spectrum. So once again, this is another slide from Macmillan, essentially showing that we are all going to live longer and the demand for palliative care will rise. So in 2040, you're looking at, in 85-year-olds, you know, 300,000 deaths. So, you know, this is something that we really need to make high priority and really have on our radar to prepare ourselves to manage these people and optimize their care.
And I think the reality of the matter is COVID-19 happened last year, and it really brought to life how important community pharmacists are to the NHS. Was probably one of the few healthcare workers that were on the front line, patient facing, and end of life care still was, people were still dying, people still needed support, and pharmacists were there. And I think it's very, very important for us as community pharmacists to really feel confident in being able to deliver that degree of patient-centered care.
Okay. So there are lots of misconceptions about end-of-life care, and one of those is that it only applies to cancer patients, and that's quite simply just not true. I mean, in cancer patients, it is easier to recognise when they might be approaching the end of life, but there are a huge number of non-cancer conditions where we can recognise that somebody's potentially approaching the end of their life. So obviously end-stage heart failure, renal failure, COPD, motor neurone disease, there's a whole host of conditions. And a lot of people think, oh, you know, end of life care, well, that's only sort of, you know, that's only really a priority when we think somebody's actively dying. But we know that if you recognise it early on, there's more you can do, there's more preemptive things that you can do to support that individual. And quite often community pharmacists think, well, what, you know, what can I do? You know, and there's just so much that you can do. You know, what Zara has sort of reiterated now, and you know, we're going to talk about over the course of the talk, really, you know, where you can make a difference. So Kerry Tomfers, she's a GP. She came up with this concept of the gold standards framework. So this was all about trying to improve the organisation of people who had palliative needs. And it's all about identifying those who are approaching the end of life, and we certainly look for particular clinical indicators that might suggest that somebody would be approaching the end of life. It's all about assessing their needs and then planning their care, because we know that being preemptive and anticipatory is so much better for that individual and their family, and for us, rather than sort of reactive care. And next slide, please. And they talk about the gold standards framework. They talk about the 5 E's. So that's ensuring that patients' symptoms are well controlled. And obviously you will see patients and their families on a regular basis picking up their medication and coming in with queries. You know, so you're so well placed to be checking in with somebody and seeing how they're doing with their medication. You know, are their symptoms well controlled at the moment? If they're not well controlled, signposting them to the right help. And The enable is all about enabling people to understand they've actually got a choice in where they prefer to be cared for at the end of life. And we know that if people state that and it's communicated to others, that they're more likely to achieve their death in the place that they want to be. We want to encourage people to participate in this concept of advanced care planning, and that's something we'll talk about at the moment. And explaining to people that they do have choices, and signposting them to a GP or a nurse or one of the members of the palliative team. We can have conversations that we can record their choices and communicate them and make a difference. And it's all about empowering carers. We know that, one of the reasons a big reason for patients ending up in hospital at the end of life is because of carer breakdown. So it's really important that we are actively, listening to what their concerns are and supporting and signposting them. And then obviously education is key for everyone within our teams, certainly within our practice, right through from the receptionist to the GP to the practice manager. So you need to be thinking about the education of your entire team and how they can help care for these individuals. And just to say that, there's NICE guidance as well to back this up. They've got guidance around final days of life. So what I talk about now is all backed up by that guidance too. So this is obviously quite a busy slide, but it was just to illustrate this is what we use locally, and it was the sort of health teams and the social teams came together and said, what should we be doing for these patients as they approach the end of their life? And it's helpful to us to sort of divide it up in our heads into a prognosis of maybe a green stage where things are generally quite stable, amber where they're becoming more unwell week by week, red where they're becoming more unwell day by day, and then not forgetting that really important care after death. So it's a bit of a checklist for us to think about what we should be doing, and there's very medical things on there, obviously around medication, but our patients who might have a prognosis of less than 6 months, they can qualify for things called DS 1500s, which allows them to have their benefits applications and attendance allowance fast-tracked and to obtain the higher rates of benefits. They can have applications for blue badges fast-tracked. Everybody who is a carer is entitled to a carer's assessment from social services. So, it's a sort of covers a really wide spectrum of things, and lots of other jargon that's on here we will be talking about through the next slides. So one of those jargons is this concept of advanced care planning. So essentially it's a voluntary process, but it allows somebody to take back some control, because quite often when they're given a diagnosis, they feel that control in their lives is sort of slowly slipping away. And so it's enabling them to have a conversation, being able to have a think about what's important to their care in the future. That might be around where they want to be cared for, who they want involved with their care. And there's also this thing called EPACS. It's our electronic palliative care coordination system. So within the GP and community records, there are templates we can record pertinent information about these individuals' diagnosis, particularly what medications they're on, what their sort of treatment plans are. So, and then that information can be shared with the out of hours teams, so that if they ring up in crisis in the middle of the night or got questions, they've got a certain amount of, reliable, good information to start the conversation with. And our EPAC system is actually based on that colourful slide I sent you back there, that sort of checklist of what we should be doing. So it acts as a sort of good reminder to jog our brains. And we know that actually if you end up on a palliative register on our EPAC system, you are more likely to achieve your goals. So, you're more likely to achieve your preferred place of care at the end of life. So just to go into detail, this advanced care planning a little bit more detail. So I realise that, you know, you might hear this sort of jargon and not maybe understand what it is. And I realise you might not be sort of leading necessarily on this, but I think it can be helpful to know from a sort of personal perspective and thinking about your wider family as well. So as I say, it's this concept of thinking about your care in the future. And if there was a time where you couldn't express what's important to you, you know, how will people know what's important to you? And when people have to be involved in making very important decisions, and if they don't know what you want, that can be very, very stressful and feel like a big burden. So there's various components to this. So one of them might be you might make an advanced statement of wishes. So that might simply be say, well, I'd like to be cared for at home at the end of life, or I want to be cared for at the local hospice. Or it might be, you know, I want such and such involved with my care, but I don't want somebody else involved with my care. Or it might simply be, you know, what I want happen to my dog, or, you know, when I die. So all sorts of different levels. There are more sort of legal advanced care planning issues as well. So that's something like an advanced decision to refuse treatment. So it might be that an individual makes a decision that they don't want to be ventilated if they have respiratory failure, or it might be that they don't want to have cardiopulmonary resuscitation, or it might be that, you know, they feel that they don't want to have a feeding tube, you know, so they can detail that. There's also lasting power of attorney. So there's two sorts, one's for finances and welfare, and another for health and welfare. One's for finance and property. The health and welfare one can only be used when somebody's lost capacity, but essentially you give somebody else the power to make decisions around healthcare if you've no longer got the capacity to do that. And then there's this concept of a respect form. So we know that obviously in the news you only see the controversy around things like cardiopulmonary resuscitation decisions, that you always see the negative side. But in 2016 Warwick University did a study and they looked at people who had do not attempt cardiopulmonary resuscitation decisions put in place, and they weren't actually offered the same treatment options that somebody who was for pulmonary resuscitation. And, you know, we weren't recording our reasoning for these decisions and we weren't communicating well. So this then became the advent of the respect process. So just the next slide, please. So essentially, this is it's a national form, but it's an option to adopt it locally. So we've adopted it here in the Nottingham area, and it's an alternative way of discussing and making and recording recommendations around care and treatment. So it might be something that a patient really wants to consider, a particular medical treatment they do want to consider. It might state that, you know, they've decided that they don't want to pursue a particular course of treatment, or they've decided now that they want to remain at home for all their treatment. They don't want to go off to hospital again. So it focuses on treatments that are to be considered, as well as those that shouldn't be considered, and also those that just wouldn't work for that individual. And within the form as well, there's the ability to put a resuscitation decision down. So somebody with a respect form might be for cardiopulmonary resuscitation, they might not be for cardiopulmonary resuscitation. So the detail of what's on it's really important, but the key thing is that this will be a huge, you know, useful source of information for that first responder who comes in a crisis situation, emergency situation, where that individual can't tell us what they want. So hopefully that can be used as part of the clinical decision-making process. Next slide, please.
Sorry, before we go on to the next slide, when a patient gets told that they are quite possibly end of life and they have a conversation with their doctor, it's usually their GP, they get bombarded with lots of jargon, lots of information. And I don't know about you, but sometimes when you leave the doctor's room, you tend to forget most of what was said. And imagine that being an end of life conversation, that patient is going to be experiencing so many different types of emotions, and statistically being backed up. Lots of patients, 50% of what they hear in the doctor's room is almost forgotten about. So although Dr. Sharkey has talked about lots and lots of different concepts and lots of different words and lots of different meanings, I think the important take home message of this is just to have an awareness of what that patient is going through, so that you as a community pharmacist, you could quite possibly be the first person they speak to after speaking to their doctor. You don't want to be sort of looking up on Google or trying to find useful resources at that point in time. You should feel confident knowing where to go, what to speak to the patient about, and that is how, as a community and as community pharmacists, we can deliver effective patient-centered care, because at the end of the day, it's all about the patient and what we can do to help them.
Okay, and so a little bit more jargon, but as I say, just so that if you hear it in the future, you think, oh, I know what that's about. So after the controversy of the Liverpool Care Pathway, they reviewed the whole process and decided that we needed a new way of managing care at the end of life. The principles were great, people just weren't using them in the correct manner. So we talk about the priorities for care of the dying person. So that's somebody who you recognise might be in the final days of life. And it's all about recognising that they're dying, check there's no obvious reversible cause to that, and actually telling everybody involved that you're expecting that somebody's at the end of the life and time may be short now. So where everybody's prepared. It's constant communication, it's involving the patient and their loved ones in all decisions that are made, supporting them in caring for their loved one at the end of life, and having an individualised plan of care. And that's the thing, it's all about individual care, individualised symptom management, conversations about what to do around food and drink, and other things that, spiritual support, all sorts of things. So a real sort of holistic approach at the end of life. And from obviously when somebody gets to the dying days, things can change quite quickly. So, symptoms can change, medication needs can change quite quickly. So in the community, as sort of GPs and pharmacists, we need to be able to respond in a quick manner to these requests for, medication, reviewing things, as, time is short for these individuals. So we want to get it right for them. Next slide, please. Okay. So obviously, when our patients have palliative needs or end-of-life care needs, they can be suffering with a huge range of symptoms, physical symptoms, emotional symptoms, so, that will have a sort of social, spiritual dimension to them as well on many occasions. But the principles we always think about are the things that we can do to reverse the situation or the cause of it. Are there things I can do from a non-drug point of view? And are there things, does this patient need medication to help with this symptom? And thinking about the choices there. So we always work to those principles. Next slide, please. So how many have we got? 35. So that's not too many, I suppose. So tell me, just put in the chat, or you can put up your hand to say, what would you think if somebody brought in a prescription like this to the chemist? So obviously where the word dose is, the GP would have actually written a figure for an actual dose. But yeah, what are your thoughts when you see something like this?
The aim of this is to be extremely honest. It's completely anonymous, so we won't know who's voted that they're not confident or they are extremely confident. It's just to gauge really how we would feel looking at a prescription like this. Would we know exactly what everything is being used for? Would we know how to counsel our patients appropriately? And yeah. Okay, amazing. I'm just going to let everybody carry on voting because Christina is now going to tell you exactly what each medication is being used for.
Okay, so it's going to be that. So essentially that prescription is something called an anticipatory prescription. So we encourage others to recognise when somebody might be in their final weeks of life. So that might be where they see them and they're deteriorating week on week, and you think they're approaching the end at this stage. And we recognise that as part of dying, quite often people are unable to swallow their usual oral route. So we need to be thinking about an alternative route of medication. So we put together this core 4 drugs, and then along with the water for injection. So between those core 4 drugs, we'd hope that we can manage the majority of symptoms that a patient might experience at the end of their life. So we know that 80 to 90% of people will experience some degree of terminal agitation. And yes, we're always thinking, is there something we can reverse? So if somebody's agitated, we always say, double check that they're not in urinary retention, double check they haven't got fecal impaction, or are they in pain? We can do something about those things. But quite often at the end of life, the agitation is a reflection of general sort of organ failure at that stage. But there are sort of non-pharmacological things that we encourage, carefully talking through things and interventions as we do them, ensuring that this is not the time to rearrange all the furniture in the bedroom, keeping things familiar, ensuring that sort of people are around, familiar voices, and that even when people might be semi-conscious or appear unconscious, that we're still talking to the individual. But quite often we do need to think about medication for these individuals to control their symptoms. And we're looking at two sort of groups really: the benzodiazepines, so something like midazolam, or the antipsychotics. So locally, our first line antipsychotic is the levothyroxine because of its ability to help with nausea and vomiting as well. But in other areas, they quite often use the haloperidol as that option. And then thinking about breathlessness, opiates, so breathlessness, clearly early on in the journey, be thinking, is there something reversible that we can do to help this patient with their symptoms? Have they become anemic? Would having some blood help, or some iron infusion? Have they got a infection that they could have antibiotics for, or have they had a PE? But it might be in the final days of life that you're not able to reverse what the underlying process is, and that you be using opioids to control breathlessness. And obviously that might seem really frightening or odd to be suggesting about using that. So there might be lots of anxieties around using sort of morphine to control breathlessness, because most people think, well, isn't that what people die of with an overdose? So that will require a lot of sort of careful counselling and exploring somebody's worries about using morphine in that instance. And obviously we're starting at really tiny doses just to alleviate symptoms. And quite often, as we know, breathlessness will be bound up with anxiety, and it's a vicious circle, and it just sort of spirals and spirals. So we might be needing to use a benzodiazepine alongside that to help manage that symptom as well. And at the end of life, quite often people might experience respiratory secretions, or some people call it a death rattle. And essentially a lot of it is caused by the fact that the muscles are weak. And that saliva that you'd automatically, those litres of saliva that you don't even think about, that you automatically swallow each day, just sort of rattle around at the back of the throat. And it's thought to be really distressing. It's really sort of distressing for the relatives, but actually it's not thought to be distressing to the individual. And I often use the analogy like snoring, because obviously that's highly irritating to the person in bed with them, but actually the person snoring sort of not aware of it at all. So we use antimuscarinic drugs. So there's options of sort of atropine, glycopyrronium, the 2 different sorts of hyoscine. We use hyoscine butyl bromide locally because it's sort of cheap, it doesn't cross the blood-brain barrier, and it mixes with those other drugs if we needed to put them in a syringe pump. From a nausea and vomiting perspective, once again, yeah, is there a sort of particular cause to it that we could treat in itself? So is it that they're vomiting because they've got raised intracranial pressure secondary to brain metastasis, and perhaps steroids might be appropriate in that instance. But if there isn't anything obviously reversible, then we're thinking, right, well, if they're controlled well on a particular oral antiemetic, it might be that one could be given in the parenteral form instead. But if at that stage you're not quite sure what's causing the nausea, or their actual oral antiemetics are really not controlling the symptoms well, locally we would use levodopa to control that. But there's lots of other antiemetics out there, the metoclopramide, the cyclizine, the haloperidol, that might be used. And then pain is obviously a big one. If somebody hasn't actually had pain through their earlier course of illness, it's not necessary that they're going to get pain at the end of life, but we always encourage that there is a small dose of an opioid available there, so that if it's an issue, it's available quickly. Once again, you're thinking, non-pharmacological management, and we always say, if somebody suddenly gets pain at the end of life, think, have they become fecally impacted, or have they gone into urinary retention? Rather than just go ahead and sort of giving opioids. And obviously at this, at the earlier stage of their illness, there's a lot more non-drug things that you can do, sort of creative distraction techniques, mindfulness, things like that, to help with pain. But we are quite often using opioids at the end of life, so that's why we need to be confident with the doses that we're considering. So next slide, please. So this is an example of what doses a doctor might write up, or a prescriber might write up, for somebody who hasn't had these medications before. So morphine, they might be starting at sort of 2.5 to 5 milligrams subcut. Quite often they're written up sort of, can be given up to every 1 hour if needed, but usually with a proviso, so many in a 24-hour period, or they've had 2 successive doses and it doesn't work, seek some advice rather than keep giving it. The midazolam, 2.5 to 5 milligrams, the hyoscine butyl bromide, 20 milligrams, and the levodopa usually sort of 6.25 to 12.5 milligrams. And we put on that initial core force prescription that you saw a sort of suggested quantity that GPs or prescribers might prescribe, just to ensure that gets somebody maybe through a weekend period until their regular pharmacist is open again. Obviously, if they're already on Zomorph or morphine, you're going to be looking at different doses and different quantities of ampules to allow them to, get through that period. So it's all about making things less stressful for the carers around end of life, and ensuring that, when these symptoms arise, that a nurse can come out promptly and deliver medication to that individual to allow alleviation of symptoms quickly. Next slide, please. And quite often nurses will need a GP to write up, or a prescriber to write up, an authorization form that will sit in a patient's home to enable them to actually administer the drugs. Next slide, please. Just put this one up really to show that if somebody's got end-stage renal failure, it might be that they are using very small doses of morphine or oxycodone to manage symptoms, but it might be that they've come out of hospital maybe on fentanyl instead, because that's more renal friendly for people with end-stage renal disease. And then the other drugs are the same really, but the doses of levodopa and midazolam, the starting doses are just a little bit smaller, but if they're not effective, they can be carefully titrated up to the next step dose, and assessing the response. And I suppose it's just really to emphasize that fentanyl is so much more potent than morphine, and I think people forget that. And so there's a lot of sort of dangers around that. And perhaps I'll just mention here as well that quite often people might be on something like a fentanyl patch. Now, we wouldn't recommend starting patches in the final days of life because, it just takes too long to reach steady state. It takes days, when we want to get on top of patients' symptoms quickly. And I think with patches as well, people forget how potent they are, because if somebody is on a 25 microgram fentanyl patch, that's the equivalent of having sort of 60 to 90 milligrams of morphine a day. And I think people forget the potency of that. So anyway, that's my little message on fentanyl that I do every time I talk. So essentially, when somebody recognises that somebody might be at that amber stage, the prescriber will organise the medication. They might put it in an actual sort of physical, what we call a just-in-case box. And we know that having these boxes with the medication actually, impacts on patients' care in a good way, in that, it reduces calls to the out-of-hours service, it reduces hospital admissions. Next slide, please. So what might be in the box? So it might be that people put their local guidelines, we do. It might be that the authorization form that the nurse needs to work to is in that as well. You obviously got the medication, we have carer and patient information leaflets explaining about the purpose of anticipatory medication, because that requires quite careful conversation, because otherwise people think, gosh, does that mean I'm going to die tonight? Or, is this sort of backdoor euthanasia or something like that? So, you'd have to be really clear in your explanation as to what these drugs are and when they will be used. And also in the box, you might have the needles and syringes, the equipment that's required for that individual. As I say, it's all about being preemptive and anticipatory and, less reactive and less crisis care at the end of life. Next slide, please. And in our area, so I know that they've got this in Nottingham and Derbyshire, certain pharmacies are paid, I think it's, I could put it down, about £266 a year to hold a dedicated list of drugs that might be required in the palliative situation. And they are reimbursed for any sort of expired stock. So that it's really helpful to us that, if actually we go in and we think, somebody needs this medication now, we know which pharmacists in the area. It's generally the bigger ones that are open longer, actually stock. They are paid to stock that medication. So that if you direct somebody to that chemist, and obviously we don't usually direct people to particular chemists, but we can show them the ones that should hold that stock, because we certainly don't want people running around different pharmacies to get the rest of that medication at that stage in somebody's illness. Okay, next slide, please. So Zara, I think you take over here.
I feel like Christina has talked far too much and you guys need to start suffering with a little bit of me. So I need you guys to use the chat function, the raising hand function, anything, everything. What do you guys think the most common side effects of oral opioids are? It seems like a simple question and probably does actually have a simple answer, but a refresher is never a bad thing. So please, guys, could you please put answers in there? I'll give you the answers anyway, but lovely, Jane. Thank you very much. Okay, I know it takes a while to type and stuff, but I don't want the awkward stare of death from me to the screen. So I'm just going to move on and tell you guys what the most common side effects of opioids are. So as Jane has mentioned, the first side effect is nausea, which is apparently the most common side effect. And as community pharmacists, we are in the best position to advise patients, counsel them, and provide solutions to potential side effects that they might experience. So the first thing is nausea, which we know subsides after a few days. So what you're going to tell a patient when you are giving them a prescription that has an opioid inside, you're going to say you might experience nausea, but what you're also going to do is make sure that the patient has some sort of prophylactic antiemetic, because that is nausea. I don't know if you guys have suffered with nausea, vomiting. It's not fun, and a patient suffering with nausea at end of life is not something that we want to encourage. We want to sort of deliver that effective patient-centered care and ensure that we're giving patients an antiemetic and you can liaise with the patient's GP, you can speak to the receptionist at the doctor's surgery, or liaise with the nurses at the doctor's surgery, just to make sure the patient has a prescription. You can just make the suggestion and raise it up. The next side effect is constipation, which does not subside with continued use and has both pharmacological and non-pharmacological. That is a very complicated word. So yeah, they have different types of solutions. So the first thing is dietary measures, which we would provide to our patients, but prophylactic laxatives is probably the most effective way of dealing with constipation with opioids. And there are different types of opioids that you can prescribe, and the most common one is Senna, but please make sure that you're always referring to the most up-to-date guidance when making your suggestions. And also, different types of opioids actually cause different degrees of constipation. So the patches tend to cause constipation to a slightly lesser degree than the oral version, but obviously, if your patient is telling you, I feel constipated because I'm taking an opioid, and that is the only side effect they're experiencing, we're not going to tell the patient's GP, by the way, they've got complete pain relief, but they're constipated. Can you please change their pain relief? That's just not going to happen. So think practically when you're making interventions with your patients. And dry mouth, it was actually mentioned earlier in the chat that dry mouth is a very common issue that patients experience at the end of life in general anyway. So as a pharmacist, what we can do is we can check the patient's PMR, we can check their records to see, are they taking any other medicines that might be causing a dry mouth? Does the patient necessarily need to be taking these medicines? We can ask these very important questions. And another good thing we can do is provide them with good oral hygiene recommendations, recommending the uses of frozen ice chips or even frozen citrus fruits. Now, as pharmacists, we actually have an NHS contractual agreement to deliver public health advice to our patients. So it's actually our responsibility to ensure that we have the information to hand, or we're able to signpost our patients to the information necessary. And also the last side effect, which was mentioned on the chat, is sedation, which again subsides after a few days. So it's important for us to speak to our patients about driving, using or operating heavy machinery, the laws that surround driving and taking opioids, and also alcohol. And again, looking at the patient's records just to make sure, are they taking anything else that's increasing the sedation? Is there something that could potentially be stopped? Our forte is polypharmacy, so we need to use all of the sort of the PMR, the SCR, the summary care records, everything that we have to hand to be able to deliver effective patient-centered care and make these interventions. So I've quite simply turned it into ABC because I can't forget that. So when we have a prescription for end-of-life care, we need to think antiemetics, breakthrough pain, and constipation. I'm sure you'll all remember this after the webinar.
And we did a study of our out-of-hours service and found that this was some years ago now, that one of the biggest cause out of hours was somebody not having any breakthrough pain. So they were on morphine, say Zomorph twice a day, but then they didn't have anything to take in between times. So, it's quite an easy thing to ask whether they do, and if they don't, perhaps, suggesting that they approach the GP about organising something for that.
And what is our role as a community pharmacist, which is probably the question that I've asked myself multiple times. What can I do for somebody who is approaching end of life? What can I do for their family? What can I do in general? Because it's a topic that we don't really speak about that often, but it's a topic we do need to talk about. So the first thing is information sharing, knowing where to signpost our patients to. Do we know what local resources we have available, any sort of national services that are available, and essentially just telling our patients about them, telling our patients' families about them when they ask these questions. The main role as a community pharmacist, again, is to reduce uncertainty. The patient comes to you and probably sees you, or their family, in essence, sees you the most. You're the healthcare professional that they have the most contact with. So your job is to essentially give them that confidence that what is happening, the pathway of care that they're undergoing is right. And you're giving them the advice they need, the counselling that they need, so they feel that they can turn to you when things might go a little bit south, or they have a question that's on their mind. So how can you get actually started? Just make time for conversations. And I know sometimes it can be such a difficult thing to do because in community pharmacy, we get so busy. We have queues to think about, items, scripts, services, there's the lot you need to think about, but making time for patients, even for a few minutes, can make a massive difference. Making sure you've got that privacy, so you've got your consultation rooms available, use it wisely. Don't have that conversation over the counter or on the side where people can hear you. And then also letting your patient know that you have time to listen to them. So sometimes what happens when we're in community pharmacy, the patient can see that we're busy. And if we make it more apparent with our body language and our language, they don't tend to share as much as they should. And we can't actually make those interventions that we need to. And active listening, just listening to the patient by asking these open questions and just taking their concerns on board. And the most effective type of communication is nonverbal communication, having the eye contact with the patient and making facial expressions that show that you're actually listening to the patient. And remember that every single patient will cope differently. So some patients might start joking about their illness, making jokes about it. It's their way of coping. They're using humor as a method. And it's important that you as a pharmacist don't make them feel sort of awkward about making those kind of jokes. That's how they're coping with it. You just need to provide them with that supportive network to allow them to make comments about themselves. Some of them might just want a little bit of reassurance from you to say, do you know what, I'm here. If you've got a question, this is the number for the pharmacy. If you don't have it, pop in. I'll make time for you. Make regular appointments with them. Do whatever it is you need to do to make sure that patient has an effective safety net. And again, it's a time-sensitive service. So like Christina mentioned, we've got some pharmacies that have the palliative care medicine stockist scheme, but just making sure you have some amount of medication that is necessary to keep them going for a few days, especially if you know this is a regular patient of yours. Those are medications that you need to make sure you have in stock. And MDT collaboration, your GPs, your receptionists, district nurses, Macmillan nurses, everybody together will help the patient. It's not a, this is your job as a community pharmacist, this is all you need to do. It's everybody has a part to play with this patient's care at different journeys, at different stages of the journey, but we all have a role to play. And remember, it's not just you, it's your entire team. You've got a team of dispensers, pharmacy advisors, healthcare advisors, technicians. You've got other pharmacists. You might even have trainee pharmacists, pre-reg pharmacists. Use them wisely and allow them to recognize the prescriptions that might come through that could be end-of-life care, and sort of teaching them the appropriate communication skills that they need to have if a patient's family member is coming back with unused medicines that could be from an end-of-life patient. Just knowing how to deal with that and just being reassuring is the key thing here. And finally, talking about dying, which is probably the most uncomfortable subject you could ever pitch to somebody, but you need to sort of use your phrases wisely. Not if it's going to be a family member coming to you and sharing their sort of emotions about how they're feeling about a family member that's passed away. Just asking how they're coping, saying, are you finding it difficult to talk about? And rather than saying things like they're in a better place or don't cry about it, it's done, we need to be a bit more sensitive with the language that we use for both patients and family members. Now, when we have a prescription for end-of-life care, sometimes we'll start off quite possibly as an oral medication, but towards the end of the life, patients swallowing difficulties might arise. So making sure that there's subcut versions of the medication available, and just being aware of, again, the local services that are available, and just being aware of the urgency. If a prescription comes in that looks like it's end of life, your team members recognize it's an end of life prescription, they're going to flag that to you, and you as a pharmacist are going to make sure you're having that conversation with the family member. You're going to be speaking to the patient. Regardless of who it is, you're going to make sure that prescription is dealt with urgently. And following a patient death, you are going to be dealing with the patient's family or their carers. So unused medicines being disposed in the correct manner. Most of the medicines that are used in end-of-life care are controlled drugs. So you might have to enter them appropriately in particular registers, but just having that conversation appropriately, either by yourself or by your team members, needs to be done in the right way, because after a patient dies, you sort of want to help keep the door open for the patient's family members to come back to you if they need something. And I do quite like a model. So the Sage and Time model is probably one of my favorite ones, and something that you could use as a checklist actually. Looking at your settings, so considering privacy, asking these open questions. Can I ask you what you're concerned about? What do you want to talk about today? How can I help you? and gathering all of their concerns and asking the patient, do you know what, is there anything else that's concerning you? Having that empathy and providing sympathy and being sensitive about the entire conversation and talking. Does the patient or family members have somebody to talk to? And the people that they have available in the support network that they have, can they talk to them? If they can, what can you do? And what do they think is going to help them? And finally, what is it that you'd like me to do as your community pharmacist? How can I help you? Because what you want to do is you want to ensure you've got shared decision making happening here. If you have a patient coming to you with certain concerns, you don't want to be bombarding the conversation. You want them to lead the way and tell you what they want from you, what they think is possible, and then you can afterwards tell them, this is what you could do. You could speak to your GP about this, or you can come back to me and we can talk about what options you have available. And finally, just summarizing everything and asking the patient if it's okay to leave the conversation there, because they might not actually be finished. And the last thing is MDT collaboration. So I've listed just a number of different types of healthcare professionals you might come across during your time with a patient that has end-of-life needs. It's just important for you to be aware of who they can speak to and what each role actually does. And like I said, polypharmacy, one of our fortes as community pharmacists in general, there's lots of tools available and out there. So I've listed different types that you can use, not use. You can share this with your teams, you can share it with anybody and actually use them to make these great interventions, deliver that patient-centered care and allow patients to experience the end of life in the way that we would want anybody, any one of our family members, a loved one to experience. And finally, I have a case study that we've so lovingly created for you guys. So this is just to check whether everything that me and Christina have talked about today has worked. Have you learned anything today? Or just a way of consolidating what we've talked about if you're just now listening. So Mr. Holloway, 60 years old and is a regular patient at your pharmacy, comes every month to pick up his medication, has very pleasant exchanges with you and your team members. He was diagnosed with stage 4 small cell lung cancer and is now being managed by the palliative care team and his local GP. Initially struggled with his diagnosis and was worried that he was going to be in pain constantly. And you actually spent a lot of time, quite possibly using the Sage and Time model, can I add, explaining symptom management, and you signposted him to local groups. So this is what his current medication looks like. You've got your paracetamol, some Oromorph solution that he's taking when required, and some Zomorph twice a day. He then comes into the pharmacy with a brand new prescription of Zomorph 30 milligrams, and he's told you that the doctor's told him he needs to take 90 milligrams twice a day now. He tells you that his pain management isn't giving him any relief at the moment, so now he has upped his dose of Zomorph. He's also been told that he needs to carry on with the paracetamol and the oral morphine for any breakthrough pain, and tells you that he's worried that he's loading himself with lots and lots of medicines and feels quite apprehensive about taking this medicine home. So just this bit of a reflective question. I'm not going to test anybody, but what would you actually do in this situation if that was you? Because this is something that could quite possibly happen to you. When would you actually refer Mr. Holloway to somebody? I'm going to get Christina to share her answers because she seems quite smart. She is a doctor after all. So, Christina, what do you think
perhaps people should put some things in the chat, I think, really, or if they want to, put some hands up, just see what your ideas are, because you probably thought of things that I haven't.
Yeah, share your answers in the chat. If you've got a suggestion that you want to tell us, raise your hand and we'll get round to you. Or use the chat box if you don't want to. Okay, so Udi has said use a pain diary. Jane has said ask him what his main concern is. Yeah. And Akirit has said, what does the patient actually know, or what has he actually been told?
Yeah, absolutely. So this sort of loading himself up with lots of medications is a sort of one of these what we call a cue, and picking up that can be quite revealing. Is it worried that he, is going to overdose himself, or actually he's been having some side effects so far that he's not keen on increasing the dose, or somebody he knows took too much morphine and this happened to them, or is worried it's going to make him vomit. There's lots of things that he might be thinking, might be worrying about about this. Pain diary, excellent suggestion. You know, it's really helpful to us as prescribers to be looking at, you know, are they actually taking the medication? What time? Are they taking it at the right time? You know, with the Oromorph, how many extra doses are they needing a day? If they're needing lots of extra doses and it's actually the Oromorph works well for them, we haven't got that Zomorph dose right, so we need to be reviewing that. So absolutely, you know, that's all key. And then I think we've got, yeah, somebody's mentioned constipation. So yeah, are they getting side effects from what is already on? Emphasize it's his choice in taking medications. Yeah, okay, yeah, so it's his choice. And yeah, so, and I think sorry, you'd mentioned sort of pain ladders and things like that before, about, you know, starting with sort of things and building up as needed and keep reviewing it. And so I think really you've sort of covered most things there. I suppose the only thing that I would emphasize as well is if that you just go back to his, yeah, excellent, yeah, is he taking other products as well that might impact or interact with new medicines or things he's on already? Absolutely. The other thing just to note, and I haven't mentioned it so far, is that as a prescriber, we normally work out the breakthrough dose by adding up the amount of oral morphine, say, they have in a 24-hour period. So so he's gone up to sort of 90 milligrams twice a day. So the way we work out how much they should be having for breakthrough is that we generally divide it by 6. So that is about 20 milligrams of Oromorph. So if he's having only 5 milligrams of Oromorph when he's having breakthrough pain, yet he's on 90 milligrams of Zomorph twice, that's probably not going to be enough for him. So it's really important that if prescribers are increasing the background dose of Zomorph, that breakthrough dose keeps in line with that. And, you know, across sort of different countries and different areas, it might be somewhere between a 6th and a 10th, but it might be something that you pick up and you think, actually, I think this Oromorph dose needs to be changed now, and you'd be signposting them back to the GP or the prescribers just to make sure that, you know, see if that needs to escalate as well. Any other thoughts about that, Sarah?
Kirit has actually mentioned taking herbal medicines or anything over the counter.
Yeah.
And again, as pharmacists, yep, that is something that we need to look at. But I don't know about you guys, but I was thinking more of the acronym that I mentioned earlier, ABC. So antiemetics, has the patient been prescribed an antiemetic? I'd probably ask that question. Breakthrough pain that Christina mentioned, and also constipation that was mentioned in our chat earlier. Now, Mr. Holloway comes back a couple of weeks later to you, and he started this new dose of Zomorph after you convinced him and gave him the information that he needed to make that decision for himself. And he felt less apprehensive about taking the higher dose. Now, the pain has been controlled much more better than before, but he's been experiencing a few symptoms of constipation and not feeling like his usual self since starting the new dose. So you've deduced from his description that he's experiencing both nausea and constipation. And Mr. Holloway wants to continue to share that he doesn't actually want to take this new dose anymore because of the side effects that he's experiencing, and wants to go back to the old dose despite the fact that it didn't actually manage his pain. What would you say to Mr. Holloway, and what impact do you think that can have with the compliance of laxatives? Again, please use the chat to share what you think. Yep, Lorraine, what is important to him? Yep.
Mm-hmm. Yeah, absolutely.
Any other thoughts? That's correct, James. Clarify that he's experiencing both nausea and constipation. Don't want to rely on the possibly incorrect deduction. Maybe an incorrect choice of words there, James. Nausea may reduce down over the next week. That's right. So again, if we use the ABC acronym, if we know he's got an antiemetic, if it's causing him a considerable amount of discomfort, then we can recommend him using an antiemetic. But again, it's providing him with that support around him. But I feel like everybody's just, you know, waiting for the doctor to tell us what we should be doing with this patient.
No, that's fine. No, I think you've got it all, and I think it's going back to those things like the ABC, the things that you mentioned to begin with, isn't it? So it's reassuring him that although he might be feeling nauseous at the moment, it's quite common to see it with an increase in dose. 50% of people might get nauseous, but by the time the week's out, hopefully that's settled down. And the GP could organise him an antiemetic, to try and relieve some of those symptoms. But hopefully for him, that's not going to be an ongoing thing. Another, simple things that, it might be that you want somebody else to take over the cooking, so to remove those sort of smells and things that might sort of just, make that sort of nausea worse. And I think sometimes nausea is worse than actual vomiting, isn't it? Because sometimes you vomit and you feel a lot better, but that sort of ongoing nausea can be really horrible. But yeah, so a lot of reassurance. And then thinking about the constipation treatment options, and once again saying that it's very common when people are on opioids to get constipated, but it doesn't mean that you still get an effective pain medication. You can continue that. We just need to sort out your constipation in other ways, and obviously all the sort of dietary things you'll talk about, but from a medication point of view, a stimulant is often the best thing to start with. In our area, our sort of first line tends to be Senna or Bisacodol. In the past, we used to use Codanthrammer, but it causes quite bad. And if somebody becomes incontinent as they sort of go on and become more unwell, it actually causes quite bad sort of skin burn. So we don't use that so much anymore. So yes, so Senna, Bisacodol, and if that's not effective, and quite often we go up in sort of higher than sort of routine doses, but we might add in a Macrogol, or maybe some Docozet, sort of more sort of softener into that approach. And I think it's really important to be preemptive at that. So you see he's increased his dose, so of his Omorph, so he might need to increase his laxatives to keep alongside it, so that you're ahead of the game. And I think generally, I mean, there are sort of really sort of specialist things that we mere GPs are not allowed to prescribe. They know the methyl naltrexone and things like that. But somebody who's under some maybe specialist palliative care services, very occasionally, if they've got really intractable opioid-induced constipation, they might go on to something like that. But that's really rare.
Okay, amazing. I'm just a little bit conscious of time, but I'm glad to inform you guys we're nearly at the end. We've put together a couple of resources that we've used as references for collating this particular webinar, so feel free to access them. There's books on palliative care, there's some local guidelines, and a pocketbook on palliative care, which I find very useful to use. And also there's a course on the CPPE website, 6 modules, fundamentals of palliative care. Definitely worth signing up to. And if you're like me and like using your apps on your phone, there's a number of different types of apps that both patients can use and you yourself can use. So yeah, it's worth checking those out as well. And again, pharmacy support. What support can you give to your patient? Just listed a couple of different websites you can refer patients to for them to have a little nosy at after they have a conversation with you. And yeah, that's just it. Wanted to say thank you, a special thank you to Lisa Dadswell for all of her wonderful support and proofreading my notes incredibly well. Thank you very much. So last year we conducted a survey to find out how community pharmacists actually felt about end-of-life care. And as you can see from the pie charts and the wonderful colors and infographics, that it's sort of borderline average confidence to a little bit confident. So we're hoping that after today, you might be feeling a little more blue, but in the right way, feeling very, very confident in dealing with patients with end-of-life care. So if you could do us a massive favor and either scan the QR code by using your phone, or I'm just going to paste a link into the chat box. Please, 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 could you fill out this survey for us? That would be really useful. It helps us to shape any future webinars, or if you guys actually found this useful at all, and if you're going to be taking these conversations to your consultation rooms in community pharmacy, sharing what you've learned with your teams. And yeah, just thank you so much for your time this evening. Christina, is anything you'd like to?
Thank you so much, everybody, for coming along on, I'm sure you've had a long day at work and it's a hot evening, isn't it? So, yes, so thank you so much for your time. I hope you found it useful.
And please, please, please fill out the survey. Thank you, guys. We will stick around if you've got any more questions. But what I will do is collate all the questions and send out a document with the slide deck, and also send you a link to be able to watch this recording again and watch my amazing presenting skills if you fancy something to watch later on if you're not bored. Right. Okay. Thank you, everybody.
Thank you.